the topic of ventricular arrhythmias and sudden cardiac death, also presented in 2015 at the time of the ESC. And it's my pleasure to introduce Carina Blomström, actually the chair who wrote this guideline, and we are looking forward to your presentation.
So thank you very much, and I would like to thank the Swiss Cardiac Society for inviting me to this very interesting Congress symposium. So ladies and gentlemen, Mr. Chairman and Mrs. Chairman, ventricular arrhythmias and sudden cardiac death is indeed an extensive document. It is 87 pages long with over 800 references. And as you can see, it has undergone an extensive peer review, 74 peer reviewers. And we have included experts from not only on arrhythmias, devices, catheter ablation, but also representatives from the heart failure community, coronary artery diseases, and so on. 50% of cardiac arrests occur in individuals without known heart disease. So when these patients die suddenly, it's of course very disturbing for the relatives if they do not know the cause of the disease. So the recommendation for the first time is to spare some blood for future molecular pathology. And this is a class 1 recommendation for patients dying suddenly of unexplained sudden cardiac death. So after an autopsy, the targeted postmortem genetic analysis can be conducted based on the findings of the victims or based on the findings in screening of relatives if there are no indications from the autopsy made. Screening of patients with suspected or known ventricular arrhythmias is, of course, very important. A 12-lead ECG should always be recorded. Patients in whom we have not recorded the tachycardia, monitoring is important, and the type of monitoring used is of course guided by the frequency of the arrhythmias that appear. So it may be 24-hour Holters, event recorders for several days, or even implantable loop recorders if the patient has very infrequent attacks and serious attacks. Signal average ECG is a recommendation to improve the diagnosis of ARVC in patients with ventricular arrhythmias, and exercise stress testing is reserved for patients with suspected ischemia or patients with exercise-induced ventricular arrhythmias, a class 1 indication. Echocardiography in different forms is important mainly to assess the left ventricular function, which still is the strongest risk factor for sudden cardiac death in general. Moreover, electrophysiological study, class 1 indication for post-MI patients with arrhythmia-related symptoms. Also, if the patient has suffered from syncope or with suspected bradycardia or tachyarrhythmia, you should consider to perform an electrophysiological study. It's a class 1 indication. EP study, however, is not recommended and does not contribute to the diagnosis or to risk stratification in patients with hypertrophic cardiomyopathy. It's a class 3 indication, and there is no indication to perform an EP study in patients with inherited arrhythmogenic syndromes, channelopathies, and it's debated in Brugada syndrome as well. If we look at the ICD for secondary prevention of sudden cardiac death and VT, it is the same class 1 indication as the previous guidelines from 2006. So patients with documented VF or hemodynamically not tolerated ventricular tachycardia, this is an indication based on the 3 trials, AVID, SIDS, and CASH. ICD implantation should be considered in patients with recurrent sustained ventricular tachycardia, except for if they occur within 48 hours post-MI. It's no difference between previous guidelines. It's a class 2A indications. A new indication and recommendation is the recommendation of the subcutaneous ICD. That may be an option if a patient has not an indication for pacing therapy, for ATP, or for CRT, because there is no pacing capabilities with the subcutaneous ICD. So this should be considered or may be considered in patients with, in whom the venous access is difficult, if a patient has suffered from infections, or in young patients with a very long time needed for ICD therapy. Unfortunately, there was a discrepancy between the first recommendation, a 2A, and the second one, a 2B, but this was voted on and the majority voted for 2B. My personal feeling is that I would like to see a 2A for this kind of recommendation still. The wearable cardioverter defibrillator is also a new recommendation in the guidelines and may be considered in patients with transient risk for sudden cardiac death, like patients that are candidate for ICDs as bridge for transplant or bridge for transvenous implant, like peripartum cardiomyopathy, myocarditis, and in patients with the early post-myocardial infarction phase, which seems very high-risk patients. There are no prospective randomized trials. There are case series and registries demonstrating quite good results with these kind of devices. Another new recommendation, which I think is very important and was missing in the past guidelines, and which may explain the underuse of a defibrillator, is the recommendation to reassess the left ventricular ejection fraction 6 to 12 weeks after a myocardial infarction, and to assess again the need for primary preventive ICD. So this was not even existed in the previous guidelines. The same holds true for the recommendation to reassess the ejection fraction after coronary revascularization, 6 to 12 weeks after coronary revascularization, and again to see if there is an indication for an ICD. Class 1 indication also, Class 1 recommendation also. So let's look at the catheter ablation recommendation. We have an upgrade for catheter ablation of incessant ventricular tachycardia related to scar heart disease and electrical storms. It's a recommendation class 1. Also, again, the same recommendation as previous guidelines. Catheter ablation is recommended in patients with ischemic heart disease and recurrent ICD shocks due to sustained VT, class 1 indication still. And we also have a new recommendation for catheter ablation should be considered after a first episode of sustained VT in patients with ischemic heart disease and an ICD. This is a class 2A indication. So what about the primary preventive recommendations? Again, no change from the previous guidelines. So ICD is recommended in patients with symptomatic heart failure, function class 2 to 3, ejection fraction of 35% or lower after optimized medical therapy. And we make no distinction between ischemic etiology and non-ischemic etiology. It's a class 1 recommendation, but the level of evidence do differ. The 2 large trials supporting these recommendations, as you know, is the SCADEF trial, only including patients in uric heart associated function class 2 to 3, EF 0.35 or less, and the MADIT-2 trial, which made no distinction with regard to the function class. For the non-ischemic patients, we have 5 primary preventive trials, which were quite smaller than these 2 large trials. And in the SCAD-HEF trial included both post-MI patients and non-ischemic patients. ICD should also be considered for primary and secondary prevention of sudden cardiac death in patients who are listed for heart transplant. It's a class 2A recommendation. This is a slight change from the previous heart failure guidelines from 2012. The recommendation is based on 2 observational studies, which together included approximately 2,000 patients in ambulatory class 4 New York Heart Function class listed for heart transplant. And we could see that the survival was better in ICD patients compared to non-ICD patients in the Sadner trial published 2001. And this was also the case in the later study published 2013. A better survival for primary preventive ICD for mortality and or need for an assist device, and or with regard to all-cause mortality and death of any cause or need for implantation. It was only a difference between primary preventive ICD or no ICD. So let's look at the cardiac resynchronization therapy recommendations in patients with sinus rhythm and function class 3 to 4. We made a distinction between patients with a left bundle branch block and patients without having not a left bundle branch block. So patients with an ejection fraction of 35% or less, and with a QRS duration above 150 milliseconds, it's a class 1 recommendation, and the same recommendation was made for QRS duration of 120 to 150, class 1 recommendation. The only difference was the level of evidence. Now, if we look at the patient groups without a left bundle branch block, we had a class 2A recommendation for QRS durations of above 150 milliseconds, and downgraded to 2B in patients with a QRS duration of 120 to 150 milliseconds. So it's a bit of a change from the previous heart failure guidelines. And it's a discrepancy now between the recent heart failure guidelines just published now in 2016, because in that guideline, CRT is stated to be contraindicated in patients with a QRS duration less than 130 milliseconds. So this is, I think, very unfortunate to have contradictory guidelines so close to each other and with no new trials after the first sudden cardiac death guidelines were published. The rationale for this recommendation has been given in the paper, and I'll present to you these trials. There was one publication in 2011. It's a meta-analysis of several CRT trials showing that CRT, of course, do better than controls for patients with a very long QRS duration, above 150 milliseconds. So that is absolutely true. The response rate was not as good for patients with a shorter QRS duration between 120 and 150 milliseconds, but the CARE-HF trial did almost come out significant. And as you recall, in that trial, patients were included based on the outcome of an echocardiographic evaluation of desynchrony. So CRT did a little bit better than the control in that trial. It was almost significant, p-value 0.06. Other trials in supportive of this discrimination between co-restoration is the ECHO-CRT study published in New England Journal of Medicine in 2013, showing that CRT in heart failure patients with narrow QRS, meaning less than 130 milliseconds, may even be harmful. So a higher death rate for CRT-treated patients. So the CRT group had a higher mortality rate than the control group, and cardiovascular events were also higher, and this was a significant difference. But I think it's important also to be aware of that in this trial, females were only represented with 30%, and we know that females are better responders to CRT than male patients. If we look at the mean co-restoration, it was only 105, so normal, so it was not an interval between 120 and 130. Another trial is the sub-study of the ECHO-CRT trial, and as we can see with the primary outcome events stratified by QRS duration, there was a significantly higher event for patients with CRT on and a QRS duration between 120 and 130. But again, females only representative with 20%. And also, this group of patients with a QRS duration of 120 to 130 were very low in numbers. And it is questionable, why should patients with a QRS duration of 120 and to 130 do worse than patients with even shorter QRS durations? So I question the result of this study, whether it's really valid and should be the base for such a recommendation, contraindicated CRT. Finally, we also have this trial not mentioned in the heart failure guidelines, but looking at the outcome with gender respect, if we look at patients with heart failure with a QRS duration above 150 milliseconds, these favors in favor of CRTD as compared with ICD. There's no difference between females and men, but for shorter QRS duration, we still have a favor for CRT treatment compared to control, but not in men. So I think it's unfortunate that we have this method of contraindication for QRS duration between 120 and 130, because we may well have females responding well to such a therapy. So let's look at the atrial fibrillation population with heart failure. This is a recommendation of 2A. It should be considered in these patients if ventricular pacing is required or patient otherwise meet the CRT criteria, and of course provided that the CRT is nearly to 100% pacing the patient, which can be achieved, of course, if the patient undergoes ablation or are treated with antiarrhythmic drugs. So a slight change from the previous guidelines. What about the patient go with mild heart failure? It's a recommendation class 1, and here we have made a distinction between CRT and CRTD according to the trial. So CRTD is recommended in this population if the QRS duration is at least 130 milliseconds, EF of 30% or lower, left bundle branch block, and for patients with not fulfilling a left bundle branch block, it's downgraded to 2B. And this is based on the MADIT-CRT study and the RAFT trial. And as we can see here in the long-term follow-up of the MADIT-CRT trial, patients with Left bundle branch block had a lower mortality as compared to the control, and no such difference could be seen in patients with QRS, long QRS duration, but without a left bundle branch block. And this is very rational because you do with synchronization, synchronize the left ventricle to the right ventricle. So a left bundle branch block should be the prerequisite. And let's look then at the cardiomyopathy recommendations. For dilated cardiomyopathy, of course, optical medical therapy. No needless to say, it's the same recommendation as earlier. ICD recommendation is also the same. It's a class 1 indication for the secondary prevention, and also for the primary prevention is also a class 1 if the patient has a New York Heart Association class 2 to 3, ejection fraction of 35% or less. Catheter ablation is recommended in dilated cardiomyopathy and bundle branch ventricular tachycardia refractory to medical therapy, and that's a class 1 recommendation. If we look at the hypertrophic cardiomyopathy recommendation, it's, I think, adopted to the guidelines that were released earlier as separate guidelines for the HOCAM only. And there is an ICD implantation is recommended in patients who have survived a cardiac arrest, of course. And of course, we have a lifestyle recommendation for patients to avoid competitive sports for the hypertrophics. And we also have a primary preventive recommendation for the hypertrophic cardiomyopathy based on a risk sudden cardiac death calculator that is available on the EEC website. And it is also a class 1 recommendation to assess the 5-year risk of sudden cardiac death every year or every second year in this patient population. So there are several investigations that should be conducted in this patient population. And no EP study is indicated, as I said before. And this is the hypertrophic cardiomyopathy risk sudden cardiac death calculator. So you would have to appreciate the age, the maximum LV wall thickness, left atrial size, the maximum outflow gradient, family history of sudden cardiac death, non-sustained VT on Holter, and clinical history of unexplained syncope. And by putting all these figures in here, we get a risk and then a recommendation, depending on the level. So if the 5-year risk of sudden cardiac death is appreciated to be 6% or higher, ICD is recommended with a class 2A level. And if the risk is calculated to be between 4 and 6%, for the same time period is a class 2B indication. And if the risk is even lower, there is no indication at all for ICD. With regard to the ARVC population, there is a recommendation of lifestyle, avoid competitive sports in this population also. Beta blockers are recommended to a maximally tolerated dose as first-line therapy to improve symptoms in patients with frequent PVCs and non-sustained VT. ICD is recommended, of course, if the patient has suffered a sudden cardiac death or poorly tolerated ventricular tachycardia. That's secondary prevention. Further on, amiodarone should be considered to improve symptoms if the patient has frequent PVC or non-sustained VT, class 2A. Catheter ablation, if performed in experienced centers, in patients with frequent PVC or ventricular tachycardia not responding to medical therapy. ICD is recommended as a secondary prevention in patients with well-tolerated sustained VT, but for primary prevention, it's only a class 2B indication with ICD. So if the patient has risk factors, it's not highly recommended with ICD, and that is related to the complications experienced with ICD implantation. One risk factor would then be a very severely reduced ejection fraction of the right ventricle and left ventricular involvement. What about VT and VF in structurally normal hearts? It's a rare disease, but we can look at the most common one, which is the outflow tract ventricular tachycardia patients. Here we have catheter ablation of right ventricular outflow tract tachycardias, or PVC. Catheter ablation is a class 1 indication after failure of an antiarrhythmic drug, which could be even only a beta blocker, or if there is a reduced left ventricular function secondary to these arrhythmias. If we look at the left-sided outflow tract tachycardias, then an antiarrhythmic agent is a class 1 indication, because it is more difficult to ablate these left ventricular outflow tachycardias, which may be located to the aortic cusp and epicardially. So here drug is recommendation class 1, and catheter ablation is 2A, and of course in experienced centers. So my conclusions after reviewing these sudden cardiac death guidelines is that there is an update compared to the 2006 guidelines based on several trials that have been published. I think in the present version it's a much user-friendly format. We still need more studies to better identify patients at higher risk of death, and also those that would benefit most of CRT. We still have even discrepancies between guidelines, even though they are a few months apart. Thank you.